Hello everyone. My name is Kaya. I'm one of the doctors currently working on the unit, IT intensive care unit in Leicester Infirmary, and I've been asked to prepare a presentation for this teaching, which is on thrombocytopenia, TTP, HAS, and HIT. The main objective of this presentation, we are going to talk about it broadly. They are quite difficult subjects. I must admit, hematology is not my strong subject, so I thought this is going to be a bit of a challenge and also appreciate complexity of those diseases. And we are going to have a look at the guidelines. Some of them are in-house, which I found extremely useful. So how we are going to do it, we are going to explore the subjects I mentioned previously. And as I mentioned, this is my approach to the hematology. It's a subject that I just have to revise over and over again because I tend to forget. And thanks God, we've got a friendly bunch of hematologists in UHL who are always happy to help us with all these various strange conditions. So let's start with the thrombocytopenia. So thrombocytopenia overall is a low platelet count. By definition, it's less than 150,000, but also it's a decrease typically in the range more than 30 to 50% from the baseline. If it still remains about 150,000, it's extremely common on ICU, and I'm pretty sure that daily we see patients who have got decreased platelet function. Studies have shown that they can be a full prognostic signs and associated with the systemic inflammation. Most of the patients, though, have got a mild thrombocytopenia and do not require further investigations. We know what platelets are doing. They are really good for us. They make sure that we don't bleed out. They are very important in terms of the inflammatory response, but sometimes they can be a bit not great and actually contribute to the severe patient status and diseases. Few things about the platelets that I'm pretty sure everyone knows about. So the lifespan of platelets are 7 to 10 days. They are produced in the bone marrow through the myeloid stem cell, through megakaryocytes and megakaryoblast, megakaryocytes, and then platelets as a little tentacles are released to the bloodstream. So all those sites and megakaryocytes are inside the bone marrow. We can divide the thrombocytopenia into mild, moderate, severe, and very severe. And I asked myself a question, where do we really have to worry about the thrombocytopenia in the patient who's on intensive care? And there's actually someone grouped it into a nice 4 pieces. So when it's really severe, when there are features of thrombosis, clinical thrombosis or HIT, we started patient on heparin, or we have quite difficult, unclear disease process. And is this actually a hematological disorder? So moving forward, causes of thrombocytopenia, multiple, actually, I think anything can cause it. But again, I found this nice division and it kind of works for me. So first one, which is quite rare, but it can happen, is pseudothrombocytopenia. What it is? So you have an EDTA sample that we usually send for a full blood count, and the compounds inside can cause the platelet clumping. Usually what's going to happen is you receive a phone call from the lab to ask to send, I think it's heparinized sample, and just so they can look under the microscope and calculate the platelets. Then thinking about easily is reduced platelet production, and that can be due to the infection, drugs, toxin from the drugs that we are using. One of the most that can cause, which I think is worth to remember, are NSAIDs, nutrition deficiency. So thinking about the patients with, liver disorders as well, cirrhosis, and then entire group of the primary bone disorders. Second big cause of thrombocytopenia is abnormal distribution or dilution. So you have your patient who had a hemorrhage, we gave them fluids, we gave them plenty of RBCs. So they are essentially diluted. Splenic sequestration, for whatever reason, we see it for patients with alcoholic liver disease. Then non-immune consumption. And at this part, I would like to say that this is not directly affecting the platelets, but can be immune in the other aspect. So you have DIC, PEs, DVTs, so massive clots and consumption of platelets, thrombotic microangiopathies, for which we are going to talk about, surgery, trauma, catastrophic antiphospholipid syndrome, or immune consumption, which means that platelets are antibodies directly against the compounds of the platelets, which is here, it can be drug immune thrombocytopenia, post-transfusion purpura, or idiopathic thrombocytopenia. So what are we doing with the patient who've got thrombocytopenia? So it's worth investigating, like any of the signs that we found. We look into the examination, so A to E, including skin, looking for the signs bleeding, thrombosis, send some labs, looking at the clotting screen, run tech if you are worried that patient is bleeding or has got DIC. The 40, so I'm going to go into a depth later on, take a detailed history. Is there something related to the recent travel, signs of the malignancy, or is this patient post-major hemorrhage? Have a look at the drug chart. Have we started new medications? Have we started heparin that can potentially cause thrombocytopenia? Imaging, if you are worried that it can be a thrombotic event or patient is bleeding, and of course, advice from the hematology. That's broadly speaking. So I was looking into the platelet transfusion, especially on the unit, and when we actually are using it, and what's the platelet count that is acceptable. So I looked into the British hematology guidelines, and to be honest, there's no clear setup in terms of the when should we transfuse the platelets in procedures, or for patients who are, who are not bleeding. But that's what they suggest. So usually looking at this for any hematological issues, platelets more than 10 are acceptable. In terms of the procedures, that varies between the, depends if you are inserting central line or is it epidural. Are we preparing patient for the neurosurgery? And in terms of the therapeutic use, so for severe bleeding, 50,000, multiple trauma, especially brain injury, 100, and more severe bleeding, 30. With when the patient has got a different hematological conditions, it can be variable. Just a flag up one thing, we have currently study running on ITU 420 to actually looking into platelets levels and transfusion for the procedures that we are performing on ITU. But to be honest with you, in terms of the procedures such as central line, all I've been told is just make sure you use ultrasound, and if there's any issues, just press for the longer period of time and you'll be okay. Of course, with the platelets where, let's say, 30, 40,000. Right, let's start with the conditions that we are going to talk about. So first one is thrombotic thrombocytopenia purpura, sorry for that. So first of all, this is hematological emergency. Untreated has got 90% mortality. LRI is the TTP service for East Midlands, so the patients can come from outside the trust. If we suspect TTP, that's enough to transfer patient over, and they're coming to intensive care in Leicester Infirmary. Of course, this is the process that's coordinated with the hematology team, hematology consultant, blood bank, and ITU consultant. So what exactly it is we all have in our blood vessel the von Willebrand factors, and there is an enzyme which is called ADAMTS13, which main job probably is to cut them, cleave the ultra-large von Willebrand factors into smaller pieces, and then it's just floating within the blood. If we have a deficiency of that enzyme, which is the most common reason for it, so it's the deficiency, the platelets clump into the ultra-large von Willebrand factor and create large clumps that are circulating all over the body, and that's what gives most of the symptoms. So thrombocytopenic purpura can be, as mentioned, acquired, which is decrease of the function of the enzyme and presence of the antibodies against the enzyme, or it can be congenital, which means that the person doesn't have this enzyme at all. But it can flag up in acute illness or during the pregnancy. What exactly drives the process, we still are not sure. So TTP is a clinical diagnosis. It's called TTP pendant. That includes fever, renal impairment, fluctuating neurological signs that constitute of 70 to 80% of the symptoms, thrombocytopenia and microangiopathic hemorrhagic anemia. However, in the most recent UHL guidelines, it's highlighted that when you have a thrombocytopenia or MAHA, that's enough to suspect TTP, and there should be the activation of the process, so directly contacting the hematology team and arranging transport to LRI. So by talking about those symptoms, what can we expect? So of course, renal impairment and thrombocytopenia, that's from the blood test. But what can you see is patient jaundice. As I mentioned, the main sign, which is fluctuating neurological symptoms, but that can be anything from having paralysis, vision issues, headaches, confusion, to dysarthria, seizures, encephalopathy, and coma. In terms of thrombocytopenia, it can be rashes, but patient can present with upper GI bleed, hematuria, or hemoptysis. In terms of what's not mentioned here is, but of course, those clots can circulate all over the body, so patient can have symptoms of bowel ischemia or symptoms of ACS, of arrhythmia. Unfortunately, when it involves the heart, if TTP involves the heart, is a quite poor prognostic sign. So we've got a patient who we suspect the TTP. We are contacting hematology. They might ask us to actually take a quite detailed history, if we can, of course, about infection, starting of recent medication, about family history of TTP, venous thrombus, any risk-associated blood-borne viruses, autoimmune conditions, or any signs of risk of malignancy. This slide is to flag up that there's lots of things that we have to do when we suspect patient with TTP, and it's quite essential. So we suspect the patient, we are going to send blood test results, of course. So apart from your standard FBC, reticulocytes count, coagulation, including fibrinogen, and the usual chemical pathology stuffs like usenis, LFTs, bone CRP, troponin, amylase, folates, glucose, there are few, and of course, group and safe because we expect low HB. There is haptoglobin and LDH that needs to be sent, and those flag up in red, which is HIV, Hep B screen A and C, as well as ADAM-TS assay, which includes levels and antibodies. And for that, you need 3 samples. Now, why is it important? Because those needs to be sent before we start patients on the treatment for TTP, which is PLEX, and I'm going to go to that in a minute. Apart from that, if you feel that the patient has got the signs of ischemic bowel, then of course imaging, or if the patient has got chest pain or dysrhythmias, is the ECG or echo, because patient can go into heart failure with this condition. Apart from that, urine dip, and pregnancy test. I mentioned blood cultures. You can have a pyrexia with this, with TTP. However, we can, look into the fact, has actually infection been caused for TTP. So what can we expect in terms of the results? So anemia, thrombocytopenia, high LDH. Usually coagulation is normal, but that can change or coexist. Troponin level might be higher, and of course abnormal renal and liver function. So on this picture, I think even for people who are not familiar with the pathology, there's something quite obvious, that there's no platelets being seen at all. And there's histiocytes and polychromasia. Histiocytes are the A, which are funny looking red cells, and polychromasia are those more purpley like red cells. So treatment. So gold standard is PEX, which is therapeutic plasma exchange. Now, PLEX should be started within 4 hours from admission, so that means transfer to LRI ITU, or 8 hours from the diagnosis, which means that's for the patient who are coming from outside the trust or being transferred from Leicester General or Glenfield. If there's a delay in terms of the starting, then we should give 50 ml per kilogram of octaplast, which is plasma. And PLEX should be continued daily. If there's a deterioration, there can be increased to twice a day for a minimum of 2 days post resolution. That means platelets more than 150,000. And now, why this patient needs to come to ITU, apart from the fact that they might be unstable, is that they need a large access. And we usually put a VASCA for that, which means that the patient can undergo the treatment. Plus, we've got a spare line if they become unstable and require a bit of they require vasopressor support. How plasma exchange is working is, in a nutshell, there's a pump that takes the blood out, filters the patient's plasma out, and replace it with the replacement plasma, and the pumps the blood back in. What it does is clears the blood from the complexes and antibodies, which means that it's a kind of replacement therapy, clearance and replacement therapy. What else can we do for those patients? So there's all the patients receive 3 days of the pulse of methylprednisolone, which should be given after the plasma exchange. We give patient caplacizumab, which is immunoglobulin that targets the A1 domain of von Willebrand factor, which prevents the interaction, von Willebrand factor's interaction with platelets. That should be given first dose IV before PEX, and the second subcut straight after the PEX. And then you continue for as long as patient is on plasma exchange plus 30 days. This is not to be given in the congenital TTP. There's of course increased risk of bleeding, so we are not with this medication because it blocks von Willebrand factor. So we have to monitor the bleeding of the if we have to monitor for any source of bleeding, and also we are not giving any antiplatelets or low molecular weight heparin when a patient is on this medication. The other medication that we can give is rituximab, so it's anti-CD20 monoclonal antibody. It's initiated within 3 days and is given every 3 to 4 days for a total of 4 doses. So those medications proven to be effective in terms of shortening hospital stay and the quicker discharge from intensive care and the lower need for the shorter days with plasma exchange. Of course, this condition is in this condition we don't do platelet transfusion, just even if they are really, really low. And if patient starts bleeding, please contact the hematology team, the hematology consultant to ask for the next steps and how to manage this patient. In terms of other treatment, so broadly speaking, ICU support treatment. So if the patient needs ventilation due to low GCSs, so intubation ventilation. If patient needs vasopressor for low blood pressure, feeding, nutrition, correcting the correctables, electrolytes, and the close monitoring. That's the other part of the treatment that we offer. So I just wanted to mention about the special cases. So the first one is congenital TTP. It's managed with Octaplast, so the plasma infusion and factor 7 concentrate. The issue is that the congenital TTP can present itself first time during the pregnancy, and I think that's the more important part, that there's a pregnancy associated TTP, which is quite difficult, as we know there are other conditions that can mimic TTP, HELP, AFLP, and DIC. There's also, as mentioned before, unmasking the congenital TTP. The important aspect is, just because we have a pregnant patient, the PEGs, the plasma exchange should be considered. Delivery doesn't guarantee remission, and unfortunately, subsequent pregnancies carry the risk of relapse and complications. As every patient, we should send ADMTS 13 assay, but there might be an difficult in interpretation, especially when there's suspicion of preeclampsia or HELP syndrome, because the level of the antibodies, because the level of the ADMTS 13 can be reduced. Apart from the plasma exchange, we can offer steroids, and there is a possibility of treatment with rituximab, but it's with caution, and of course, following a quite extensive discussion. Okay, that's enough about TTP. Let's go to HUS, which is hemolytic uremic syndrome. Sorry for that. Something that looks similar, but is different. And I think that's why it's so challenging to diagnose it. So we've got, with HOS, we've got a classic triad, which includes microangiopathy, hemolytic anemia, so MAHA, acute kidney injury, thrombosis, plus diarrhea. Of course, you can have another aspect of low GCS, similarly to your TTP. And I think that sometimes it could be really challenging to distinguish those two conditions. So we can divide primary HUS and hemolytic uremic syndrome to primary HUS and atypical HUS. So primary HUS is caused by the Shiga toxin, is the most popular. So your stec bacteria, they produce a toxin that goes to the bloodstream, knackers your gut, and then it binds to the specific receptors on the epithelial cells, and it's really in favor of kidneys. So kidney hit is primary syndrome in terms of the HUS. Diarrhea is in 91% of the cases, and 56% as a blood, usually 5 to 10 days prior to onset of HUS. So again, patient might present themselves with the unspecific symptoms of post-diarrhea and vomiting, having abdominal pain, feeling quite weak, joint pains, not passing urine, or have hematuria. In terms of atypical HUS, so this is related to mutation or autoantibodies leading to dysregulating complement activation. We can see that in transplant, autoimmune disease, cancer, pregnancy, or sometimes after cytotoxic drugs. In terms of the atypical HUS, there's a specific specific HUS, which is Streptococcus pneumonia, as a cause of hemolytic uremic syndrome. So what happens is strep pneumonia produce an enzyme, neuraminidase, that expose the antigens on the red cell platelets and kidneys. So what happens is we produce immunoglobulin, and because that leads to the hemolysis, thrombocytopenia, and renal damage. Now, in terms of the blood, very similarly, who going to call when you suspect HUS? Probably discussion with renal in hematology, renal in terms of the impairment, severe kidney impairment. Similar bloods are being sent. It's worth to discuss, especially when you have to distinguish between HUS and TTP. Would they like the Adam TS13 levels being sent as levels and antibodies? And apart from that, stool sample and PCR to look for the Shigella toxin, urine dip, pregnancy test, imaging, blood cultures, renal biopsy if platelets allow. Results very similar. It's actually very similar to TTP. So anemia with profound thrombocytopenia, signs of hemolysis, abdominal renal function. On renal biopsy, what's quite characteristical is that you've got the swollen glomerular endothelial cells, and glomeruli are impacted with fibrin-like material, red cells, and platelets. This is interesting because when I was browsing to look for blood film for HUS, it looks exactly the same, and I met in the various documents of this picture, which is exactly the same one as for TTP. So yes, it can be tricky to distinguish both of them. So treatment, similarly, supportive. There is no single overall treatment for the HUS. What is important to be cautious with fluids because, as mentioned, our kidneys are impacted. They don't work very well. So if we give too much fluids, we can lead to the massive fluid overload state, which can cause actually hypertension. A patient might need renal replacement therapy. Actually, most of them need it. Antibiotics are not advised because it can worsen toxin production. If we are talking about the Shigella, blood transfusion, of course, we are hemolyzing. We need some blood to help carry oxygen around our body. Platelets transfusion contraindicated again. PECs, if unsure, that's mostly for the atypical HUS. If you are worried about any sort of complications, again, we have complexes of little clots circulating around the body that can go to your brain, that can go to your lungs and kidneys or gut. Then, of course, in further investigation and dealing with the complications. Unfortunately, lots of patients are requiring renal replacement therapy post-surviving HUS, and some of them might need a renal transplant, but that's further down the line. Similarly to TTP, supportive intensive care treatment, airway protection, act on cardiovascular instability, feeding, so nutrition support, correcting electrolytes, and overall monitoring. When I was reviewing literature, I bumped into the drug which is called eculizumab, that is against the C5 complement protein. I haven't seen that in our guidelines or used in UHL, but I think it's something to mention too, and it's used in a atypical HUS. So there you go, comparison HUS versus TTP. Triad versus pentad, RAD versus FAT RN. I hope, not sure what RN stands for. And yeah, think about those when you see the unwell patient with the profound thrombocytopenia, comatose with some strange symptoms and not passing urine. Right, the last part of our presentation. So heparin-induced thrombocytopenia. It's a rare condition. We distinguish HIT1 and HIT2. HIT1, just a brief mention, it's a non-immune mediated mild drop in platelets that resolves spontaneously after 1 to 2 days when we start patients on post-heparin exposure, and is not associated with increased morbidity or mortality. Contrary to HIT2, the UHL guideline states that it's dropped more than 30% of platelets post-heparin exposure, and or development of the new thrombosis or skin allergy, even if platelets are above 150,000, so with normal range. Why is it? Because why it happened? Because we developed antibodies directly towards the complex formed by heparin and platelets antibodies, PF4. That's why the first symptoms usually starts 5 days after the exposure, because that's when we develop the immunity, the antibodies, and it's very unlikely. The hit is quite unlikely if the symptoms start after 10 days post-exposure. If platelets are more than 10,000, also hit is an unlikely diagnosis, and the guidelines suggest further investigations. Saying that, there are 2 specific conditions, which is first one is rapid onset of hit, and that's associated with the platelet fall, which can be up to 3 months. However, so it's a rapid fall of platelets after exposure to heparin, but usually it occurs if the patient had any sort of heparin in last 3 months. And there's the delayed onset of HEP, which can just happen weeks after the heparin is stopped, or patient has been persistently on heparin for several weeks. Regardless, if you suspect HIT, it's worth to speak to our hematology team just to express the worry, because the consequences can be pretty tragic. So there's some pictures how it looks like. So you have pictures of the necrosis and the pictures of the necrosis at the site injection and the picture of the necrotic toes. So when HIT is manifesting, don't forget that usually it manifests with some sort of thrombotic event. So that can be venous thrombosis or PE, DVT, can be atrial thrombosis. So, for example, ischemic cling, skin lesions, which at the site of the heparin injection can have a acute response, generalized response post heparin bolus, and it can be with DIC. So, what we are want to speak to our hematology colleague about suspicion of HIT. We've got a patient on heparin or low molecular heparin. What we have to do is, before we even make a phone call, we have to do the 4T score. So 4T score is the score to establish the probability of HIT, and it consists of the 4 domains: thrombocytopenia, timing, thrombosis, or do we have another cause for thrombocytopenia? If the scoring points is between 0 to 3, so it's very low probability, so HIT is exploding. What that means is we do not send the HIT assay. If the point is between 4 to 5, then it's intermediate probability, we are stopping all heparin. We consider if it's needed alternative anticoagulation and send a hit screen. And if it's 6 to 8 points, the probability is quite, so that probability about 50%. We stop heparin, start alternative anticoagulation, and we send a hit screen. So hit screen, it's a sample that we send in brown sample bottle, so it's serum. It needs to be delivered to LRI, special hematology lab, within 4 hours from sending. So before you send the sample, you have to let the lab know and organize the transport from Leicester General or Glenfields to LRI, and it cannot be done under at night. So what hit screen is essentially looking for the complexes and antibodies against heparin, PF4. So in terms of the management, as discussed before, we're stopping heparin. We're looking into another types of anticoagulants. We do not transfuse platelets. We're checking the FBC clotting. We can do TEG, LFTs, UZDs, just to have a broad picture of the patient. If we are suspected another thrombotic event, we can consider imaging, necrotic looking skin, ischemic limb, discussed with the vascular or plastic team. And apart from that, supportive treatment. The alternative options to heparin and low molecular heparin in the trust is fondaparinol, which is synthetic anti-10A inhibitor. It's dosed similarly as low molecular heparin per body weight. It requires factor 10A monitoring, which should be given 4 hours post-dose, especially if the patient has got liver or renal failure. There's no antidote for fondaparinol. Or infusion, which is agratroban. It's a direct thrombin inhibitor given by intravenous infusion. It undergoes hepatic metabolism, so it's safe for the patient with renal failure, and it prolongs APTT as well as PT. In the long run, it's important when you start patients on warfarin. In acute setting, there's no place for DOAC. Right. That's it from me. Does anyone has any urgent questions?
Oh, that was brilliant. Thank you for that. That is a lot of information in a very short space of time. Yeah, you need a drink of water after. You have just talked constantly for about 40 minutes.
40 minutes.
And given a delightful summary of all of that. I'm not going to question anything that you've said, really. Just we have the ability to have a chat with some nice, lovely local haematologists that will help us with a lot of that.
Absolutely.
Kevin, I can see you're on there. To be honest, I haven't used fondaparinol or agraban for a long time. Is that still what the trust uses then?
So I took it from our UHL guideline. I forgot to share something. We actually have got excellent guideline on HITs and TTP. So, and actually Plex. I found them recently on our SharePoint, whatever it's called now, that Facebook looking like page that we use to share information and cut video. So I do recommend having a look at that. There's so much information. Of course, if I wanted to talk about it, about it all, it would take probably an entire day. But I do recommend having a look, and it's there for a purpose. It's there so we don't have to remember all those magical drugs and and blood samples. The aim of this presentation was to flag out those issues that we have to plan when we do the plex, when we give the medications, and that we act fast if we suspect any of those conditions, because the consequences of not treating them can be futile.
So some of you may be aware, but if not, I did a QI project on brushing teeth on this unit at LRI. So this is just some of the results I had and about what we could do maybe going forward to improve this. So why I did this project, why is toothbrushing important, what I did, the results, what they showed, things that I think may benefit us changing, and then some kind of future thoughts, and then talk about some of the next steps. So I went to my dentist, as I do twice a year, and she knows where I work, and she just asked me about it. We had a bit of a chit chat about it, and I thought, oh, that's a good point. And then the next day I went to work, and I saw quite a few of the patients who've been with us for quite a long time, had very kind of lots of plaque on their teeth, and I just thought, oh, I wonder if we do brush people's teeth. And there was a few people after they'd been extubated, after being ventilated for a few days, who would be like, oh, my mouth tastes awful. So I just kind of asked around the nursing team. I was like, do we brush people's teeth? And is it something that we do all the time? Is there like a set amount that we have to do? And just kind of getting a feel about whether they think there's something that could be improved. And the general feeling from the nursing team was that it's something that we probably could be doing a bit better, which is what led to this. Yeah, it's a pace central solution for surface problems. That was the only pun I could think of for toothbrushing. So why is it important? So there actually was a meta-analysis done last year, which was based on ICU, but also some non-intensive care settings as well, where they noted that there was a trend between patients having their toothbrush daily had less hospital-required pneumonias. So it was 15 randomised controlled trials with over 10,000 patients, and they found that based on the meta-analysis there was a 33% reduction in HAPs, which also meant that the mortality of being in ICU was lower. They were ventilated for a shorter period of time, and therefore they spent less time in intensive care. And this was mainly for people who were ventilated, so people who've got the ET tubes in. So they felt that kind of brushing someone's teeth, which is a very simple, basic thing to do, was actually just quite a cost-effective, low effort strategy to reduce the amount of HAPs and infections, and also improving patient outcomes in ICU, which I thought was a really interesting paper. So what I did was I tried to think of ways to minimise workload for nurses. So because we're moving towards an electronic way of life, I had a look on Nerve Centre, and Dr. Smith pointed out that there was a mouth care bundle on Nerve Centre. So what I did was I just picked a few days in August, and I looked at all the patients who were in the unit who were intubated and ventilated and also weren't. I looked at whether they had a mouth care bundle completed twice a day. So I looked at kind of between midnight and midday, and then from midday till midnight, whether in that time they'd had a mouth care bundle completed. I looked at all patients, whether they had a trachea in, ET tube, or they had capacity to say no. And I then isolated the intubated patients as well, including trachees. So effectively people who couldn't refuse to have their teeth brushed, with the target being that they should have their mouth looked at least twice a day. And that's as per most of the nursing guidelines. I removed any patient who had gone to theatre for the day, or time off the unit, or they weren't admitted to ICU yet, say they were on the system but they weren't actually there yet. So I did that initially, and I then found out there's lots of other places that nurses can write the toothbrushing, so they can write it on the main ICU chart, and they can also write it in their blue notes as well. So then I thought, well, maybe I'll just do a quick survey from the whole MDT team just to get their general sense about it. So I did that, and I got 25 responses from that, and I did that on the 20th of August as well. So the results. So from Nerve Centre, I don't know how well that looks quite blurry on my screen. So I don't know how blurry it is at your end, but the graph on the left shows all patients, so whether they were tubed or not, and the graph on the right shows purely intubated patients. So on the left, the bottom left blue bar chart shows that there only 46.3, I think, % of patients had a mouth care bundle completed on Nerve Centre twice a day. So obviously, ideally, that should be 100%. And then I looked at it that more people had it done in the morning than they did at night time as well, which I suppose is to be expected because there's more people in the daytime. And then I also just looked at purely intubated patients, which is the graph on the right, and that showed that mouth care bundles were completed in 39.5% of patients twice a day. And again, it showed that we were completing those more times in the morning than we were at night time as well. But that is not the only way that we write down that patients had mouth care bundle, but that's one of the ways that we do it. So obviously not ideal, we should be achieving 100%, but like I said, there are other places that nursing staff can write that as well. In the survey, so the first question I asked was, what is your profession? So the big blue one is nurses, the kind of pinky magenta one is doctors, and then there's a spattering of pharmacists, physios, dietitians, OTs, and some students as well. So I asked people how often they themselves brush their teeth, and the majority, the orange, said that they brush their teeth at home twice a day. That's the majority, and one person said seasonally, which I can name and shame, but is one of the nursing staff. So most people in our day-to-day lives, they brush their teeth twice a day. I asked if you or a relative was intubated and ventilated on intensive care, would you assume that someone was brushing their teeth for them if they couldn't? And the majority of people said that yes, that they would expect us to brush their teeth for them. I asked if on intensive care, do you think that we brush people's teeth twice a day? And the pinky magenta one is no. So more than half of us felt that we weren't brushing people's teeth twice a day. I asked generic questions about why do you think we don't do it, and I consolidated people's responses into these bullet points. So some people put there was time management, there wasn't staff education about the importance of it, they were worried about compromising the airway by brushing people's teeth. Some people felt it wasn't part of the nursing role to brush a patient's teeth, not a priority compared to other jobs that the team have to do. Not clinical practice, patients can't consent to have their teeth brushed, twice a day is too laborious. Some people said it depends on who's looking after the patient, and not part of regular personal hygiene. I also asked, how often do you brush an intubated and ventilated patients? And just as a generic thing, so most people said once a day, twice a day, every shift. When they do mouth care, but they won't brush people's teeth. Sometimes they won't use a toothbrush or just use a sponge instead. So a real mixture and variety. There wasn't just a set response. I asked, do you brush your teeth with a sponge or a toothbrush? And most people, the pink is that they brush with a toothbrush, and the green is not applicable, probably because it was on the pharmacist doctors doing it, because we often don't do it, and then 4% was with a sponge. Do you think toothbrushing is important for patients to receive an ICU? And 100% of the 25 respondents said yes, it was an important thing to do. I asked if people knew of any reasons why we thought it was important to brush teeth, and people came up with reasons such as reduce the risks of hats, promotes good oral hygiene, it makes people feel human again. If they've got a nice clean mouth and their mouths taste of kind of minty freshness, that horrible taste will go away in some ways. Prevents the plaque build up. We all know how expensive dentists are nowadays. So if you go to intensive care and we save your life, and then you end up with a stonking dental bill with all your cavities and your root canals and things like that, that's something that maybe we could help reduce for patients as well. It's important for everyone. We do it twice a day, so why isn't it important when someone's on intensive care? You get less thrush as well, so we'll be giving less nystatin and fluconazole. It's a really good way of assessing someone's oral health as well by looking in their mouth, so seeing what their teeth are like, do they look after their teeth. Obviously, we see patients with often wobbly teeth and poor teeth before they come in, so if we can try and improve that slightly while they're on the unit, then that will help the patient as well. And I've already mentioned about patient's comfort as well. I asked why we didn't want to brush people's teeth. So what were people worried about? And the main point was coagulopathy. So people are worried about causing bleeding. They're worried about loose teeth. And they're worried about if there are mouth sores already there, then they're going to cause more pain, which I can understand. But then some people also mentioned that if there was any of those present, they would just use a sponge instead of a toothbrush. I asked about, so as I've mentioned, there's 3 different places for the nursing staff to document where they brush people's teeth, which is too many in my opinion. So I was trying to think of a way about, I asked where people normally document, and it's a real mix. So the blue one is the bedside ICU chart that's in front of the patient. The pink one is the blue nursing notes, and then the nerve centre mouth bundle is the green one, the purple one being the not applicable. So it's a real kind of split about where people are documenting. And then I asked where would be the most convenient place, expecting one answer, and I got multiple. So some people suggested that there should be a separate ICU checklist for it. It should be on the chart, so in front of the patient. There should be somewhere that you can tick a box for toothbrushing separate to the mouth bundle, the mouth care. Some people said nerve centre, some people said nursing notes, and there was quite a lot of not too sure. I asked whether if toothpaste was prescribed on nerve centre twice a day for intubated and ventilated patients, do you think patients would have their teeth brushed more frequently? And nearly 75% of the 25 people said yes. They thought that prescribing toothpaste would result in more people having their teeth brushed. And then I asked just any additional thoughts. So the feelings were that staff members needed more training about kind of daily hygiene needs. They felt that toothbrushing should be seen. It would be great to see more people having a teeth brushed. Some people said, I think I know who this person was. I think he's working today. So please don't prescribe it. Good Lord. For me, it's a basic human need in lots of ways, having a toothbrush. Chlorhexidine may play a role. I know it was here last time it stained people's teeth, but I think there's a different type which doesn't stain people's teeth now, which possibly would be in use. It should be at least done once a day with some people's feelings. And then someone then mentioned that prescription may help, but it doesn't work with hair washing. So, suggested changes. So I came into this wanting to prescribe toothpaste on nerve centre. I'm not saying that's the solution, but it was something that for me was like a visual trigger that it would be done twice a day if it was prescribed on nerve centre. I wonder if we could do with some further training about the importance of it, and then build confidence to allow various members of the team to brush people's teeth. I know there was a lot of talk about updating the ICU chart, but that's not exactly the smallest task in the world to undertake, to update the entire chart. On the next slide, I've got a sticker. So I've suggested maybe a sticker that we add to the bottom of the ICU chart in one of the white gaps about toothbrushing and also hair washing and brushing. So that would be something that we could just add to the current ICU chart with minimal intervention without having to change the entire whole new chart. If we are moving to more electronic-based work, then maybe we should be updating nerve centre, updating the mouth care bundle to something that is more useful for us, because right now it's more generic, but then actually changing something on nerve centre, such as the mouth care bundle, is probably a lot more difficult than I imagine it would be. So that may not be something that would be as easy as I think it may be to do. There's talk about this new equipment coming, which is a toothbrush which you can put suction on the end of it, so then it sucks at the same time as brushing teeth, which may empower some teams to use that more often if they're worried about soiling the airway at all. And then I had a thought, because I wouldn't mind doing it, is if you're an airway trained doctor and you're seeing a patient on the morning, in your morning review, why don't you brush their teeth at the same time? You need to look at their tube anyway. Well, I look at their tube anyway. And have a little look in their mouth and see what's going on. why not brush their teeth at the same time? Sorry, excuse me. That was another thought I had. So moving forward, hair brushing. So I think that's been quite topical recently on the unit. So this is the suggested sticker that I have just spent 2 minutes making, where it'd be a sticker, you've got a toothbrush morning and night, brush hair, wash hair, and then you just tick a box to say, yes, it's been done on that day. You just stick it on the IT chart every day, and it's just there. You tick a box. If you did it, I'm not saying you have to brush someone's hair every day or wash someone's hair every day, but it'd be like a visual representation, a bit like bowels not open, that it's happened. So then we can, if it's not been done for a couple of days, you're not right today. But one of my main priorities is I'm going to wash this patient's hair today, or I'm going to brush this patient's hair today, and just keep an eye on it that way. Chlorhexidine maybe making a comeback. I'm not too sure about that. If you know more about that, but chlorhexidine maybe making a comeback as well, to reduce the risk of HAPs and BAPs. So that was it. Anyone got any thoughts or questions?
Kaya?
Interesting, very interesting actually project. I like it. I just thought that maybe it would be wise to ask actually patients after ICU care, because that's our perspective. So what patients think about that? And I don't want to be horrible, but with, sometimes when we intubate those patients, some of them actually probably had their teeth brushed first time when they've been on intensive care. And I think that I do understand. I'm not saying that you shouldn't, but I think it would be good to know the patient's perspective on that as well.
Having been a patient on ITU, I don't remember being on ITU. I don't remember very much about my hospital stay, but I do remember being able to clean my teeth after 3 weeks. Oh. And it is definitely worth it. I would say that teeth cleaning needs happening, because it's disgusting if you can't after 3 weeks.
All I'm saying is that not everyone has got priority for the teeth hygiene.
Yeah.
It's a tricky one.
I think most people care about it, and
yeah.
I know I had a broken arm, so I couldn't clean my teeth, but still, being able to do it independently, even left-handed, it was suddenly massive. And yeah, we forget all the things that we always take for granted. You suddenly can't do when you're on ITU, and they are quite important actually, and it makes you feel more human.
Yeah, I mean, I wouldn't be against doing it. I mean, I'm only here for like 2 more shifts, but so I'm saying this with that knowledge. But I mean, flat hugs, which is for all ventilator patients. In my head, I was like, just stick another T on the end of flat and put like teeth in there.
Yeah.
But this is all because when I worked in Doncaster intensive care, part of the admission bundle was everybody had toothpaste prescribed, as well as their omeprazole and enoxaparin and their TEDs. Toothbrushing was part of that, and that worked for them. But I know that this is a different unit, and I know that there are a few people who don't want me to prescribe toothpaste on their centre. And I understand the reasoning behind it, but I'm also trying to think of a way for people to have their teeth brushed.
Cindy?
I have to say, I am horrified that it's never occurred to me.
I know, I thought the same thing until I was in.
I am absolutely horrified. And I do wonder if maybe we should prescribe it.
It would mean it happened if we did.
I actually don't. There clearly have been problems and objections to it. I'm not sure what they are.
It's not a drug.
It's not a drug.
Snacks aren't drugs either, but we prescribe those.
Well, pet stockings and Flotran, sorry to chip in, it's not a drug as well.
Yeah, no, I agree. So that's just nonsense. Anyway, I think it's something we absolutely need to think about. Thank you so much.
Thank you, Katie.
Thank you very much, guys. If you've got any bright ideas about how I can make this happen. It seems very easy to me, but it seems to be a lot of red tape. So any suggestions would be welcome.
But I think it's important. I stuck a feedback link up if people would like to do some feedback. For Kaya and Katie, thank you very much. I was going to say what's happening next week and I can't remember. Oh yes, I can. Sarah Oldham's, the sepsis lead nurse, is going to do a sepsis update for because the guidance has changed. That's what's happening. So thank you very much, guys. Have a lovely weekend.